Okay, so we left off talking about STEMI, myocardial infarctions, and we said that they were due to an occlusion of a coronary artery and consequently a disruption in the blood flow to the myocardial tissue, and that this can eventually lead to cellular necrosis. And we then said that patients may be candidates for reperfusion therapy. And this procedure will restore blood flow to the myocardial tissue and preserve the function of the myocardium. Here is an example. There's many terms that we'll become familiar with when we talk about this area. One of them is revascularization, and that is similar to reperfusion. In other words, we are going to open the lumen of the vessel so that we have revascularization occurring. Another term that is used is percutaneous coronary intervention, PCI. Okay, and that means that we insert a catheter through the skin percutaneously, and we advance it all the way up to the coronary arteries and perform an intervention there. And as you can see in this picture, the intervention may include inflating the balloon across the lesion or across the occlusion, and inflating that balloon so that we smack the plaque against the wall of the vessel. The balloon can then be deflated and removed, and we can also deploy a stent to leave that in place there. A drug-eluting stent, even better, to prevent reocclusion of that vessel. We find another term, PTCA, stands for percutaneous transluminal coronary angioplasty. So PTCA is another term that we'll be hearing in the cath lab, and that's what it's referring to. This procedure in which a catheter is inserted most often through the groin, but also can be inserted in the brachial area in the arm. And then the catheter is advanced using a guide wire all the way up into that tiniest of the coronary arteries to try to insert a wire across the occlusion. The primary complication of this procedure is bleeding, okay? And the bleeding is occurring at the insertion site, okay? So a lot of pressure is applied after this procedure, especially in the groin area. The alternate site in the arm has less risk of bleeding associated with it. But we don't see that as often, even though it is certainly an option for the interventionalist to perform. But there is definitely less bleeding associated with the alternate site as compared to the groin. So again, just to re-emphasize that bleeding is the #1 complication associated with coronary angioplasty procedures in the cath lab. Okay. Another term we'll hear is the door to balloon time. Okay, that means the time between the arrival of the patient who's having the ST segment elevation myocardial infarction, or STEMI, in the emergency room until the time that a balloon is inflated in the occluded coronary artery in the cardiac cath lab. Okay, that door to balloon time is 90 minutes or less. Okay, they've discovered that there's an association between shorter times to reperfusion and lower mortality rates in patients who are having a STEMI. Drug-eluting stents are metal devices that have been coated with a medication that is known to suppress restenosis. That is, it suppresses or prevents the reblocking or closing up of a coronary artery after angioplasty due to excessive tissue growth inside or at the edge of the stent. After receiving a drug-eluting stent, in addition to aspirin, the platelet's going to be placed on a second anti-clotting or antiplatelet medication, such as Plavix. Clopidogrel is the generic name for Plavix. There are other options available. Instead of Plavix, the patient could be put on aspirin and Brilinta, or Ticlid, or Effient. Okay? This type of dual antiplatelet therapy is referred to as DAPT. So when you see that acronym, you'll realize it refers to dual antiplatelet therapy. And this needs to be continued for this patient for a year, sometimes longer, after that original stenting. And that's so that they can prevent blood from reacting to the new stent. We don't want the body to, for a clot to form there. So we want to make sure we prevent the formation of any stent thrombosis. Okay, because then again, we'll have a problem with perfusion once again. We mentioned earlier that we can classify myocardial infarctions by the area that is involved. We can describe a myocardial infarction as an anterior MI, inferior, lateral, posterior, or perhaps a combination such as an anterior lateral, okay, MI. When we say a person has had a posterior MI, we're talking about the damage and death to the heart tissue that we see shown here in the picture as purple. Remember, a heart attack or acute MI occurs when one of the arteries that supplies the heart muscle becomes blocked. The blockage can be caused by spasm of an artery or by atherosclerosis with acute clot formation. The blockage results in damaged tissue and a permanent loss of contraction of this portion of the heart muscle. The severity of an MI is going to depend on the degree of collateral circulation that a patient has developed. Additionally, we can use our EKG leads to help us identify where the acute MI has occurred, which part of the heart is affected by this heart attack. Okay. I don't expect you to memorize this. I just kind of want you to have an idea that, of course, we have 12 lead EKGs. Each lead is giving us a different view of the heart. When we are looking at EKG tracings, if your patient has had, for example, we see in this picture, an inferior infarction, then you would want to look at leads 2, 3, and AVF. When we see a Q wave in these 3 leads, it indicates that the infarction has occurred in the inferior aspect of the heart. And likewise, we can see the presence of a Q wave in leads 1 and AVL if there is a lateral infarction. And finally, in anterior infarction, we see the presence of a Q wave in V1 through V4. So although you don't have to memorize this, if you go on and become a critical care nurse, you likely will end up memorizing these different leads, which will show you different aspects of the heart. And here they are listed just for your own reference if you would ever want to refer to it, but I won't test you on it. But just so you understand that we classify heart attacks based on their location, and the actual leads when we're looking at the electrical activity through the heart can guide us to what region of the heart has undergone damage. Okay. Complications of myocardial infarctions. The most common complication of a heart attack is an electrical dysrhythmia. Okay, so in 80% of the complications after a patient has a heart attack is a dysrhythmia. Sometimes these dysrhythmias may be lethal, okay, or life-threatening dysrhythmias. So that's very important that we need to be able to recognize those and interpret those on our EKG tracings. And the dysrhythmias are a direct result of the fact that the myocardial tissue is experiencing ischemia. Accompanying that, there are electrolyte imbalances and the sympathetic nervous system is stimulated. We especially will see life-threatening dysrhythmias occur when there's a myocardial infarction of the anterior wall. Remember, the anterior wall is perfused by the left anterior descending coronary artery, and the left ventricle is perfused by this LAD. So when the left ventricle is not being perfused well, it can become very irritable and lead to these life-threatening dysrhythmias. As well, we can see heart pump failure, which is also called cardiogenic shock. That can also lead to life-threatening dysrhythmias. Also, heart blocks can occur when there are massive MIs. Okay, and a complete heart block means basically that the electrical conduction signal is not making its way across the heart so that we have a synchronous contraction. So we can have disruptions in the electrical conduction system within the heart as a complication of a heart attack. Now let's practice. This is a select all that apply type of question. Okay, let's see how much you've learned already today. The nurse is evaluating the 12-lead EKG of a client experiencing an inferior wall MI. While conferring with the team, she correctly identifies which of the following EKG changes that are associated with an evolving MI. And I feel guilty here because in our lecture, I discovered that we skipped 2 slides, and I think that that slide would have enabled you to answer this question better. But for sure, I'm sure that you would get 2 of these answers, which would be E, the ST segment elevation, and also the pathologic Q wave, right? Because you get a Q wave with a heart attack, as well as we have a STEMI with a ST segment elevation. The only other thing that we did not talk about was the T wave inversion. So I will go back to that in our lectures that are coming up, because I want to make sure that you understand when the heart is becoming ischemic and there's injury to the myocardium, we can see an inversion in the T wave. Okay, so in this question, the correct answers would be C, T wave inversion, E, ST segment elevation, and F, a pathologic Q wave. Pathologic refers to a diseased process. In other words, it's not a normal Q, it's pronounced Q wave. Ventricular fibrillation is a life-threatening arrhythmia or dysrhythmia. It can be lethal, and it usually will occur within 4 hours after the onset of pain. Okay, as a complication, we're talking here of an MI. But even so, frequently ventricular fibrillation is going to be preceded by what we call premature ventricular contractions. And these premature ventricular contractions, or PVCs, are an indication that the heart is ischemic and irritable. Okay, so when PVCs begin to become frequent, it's usually going to lead to a ventricular fibrillation. This life-threatening arrhythmia requires immediate treatment. And the treatment is lidocaine. Okay? Lidocaine is a cardiac medication that I like to think of as soothing an irritable heart. Okay? So this heart is very irritable. We have these premature ventricular contractions. We have the ventricles now begin to fibrillate. They're not contracting together in one smooth motion. Okay, instead they're like quivering. The ventricles, the workhorse of the heart, are now fibrillating. Okay, so what do you think that's going to do to the cardiac output? Yeah, it's terrible. The cardiac output is drastically reduced when the ventricles are quivering. Okay, so we need to treat this. We need to soothe this very irritable heart by giving them a bolus of lidocaine. It's one of those drugs that you do have to do your math calculations. But I'm not asking you, of course, to memorize these dosages, but usually the bolus would be 50 to 100 milligrams IV push, or more specifically, it'd be 1 milligram per kilogram of the patient's body weight. This is followed by a continuous drip, and that drip would be at a lower dosage of 0.5 milligrams per kilogram. Okay, so again, you start with a bolus and you follow that up with a continuous drip. Okay. So let's look at what is a PVC. A PVC is an indication of an irritable heart. Okay. And a heart becomes irritable when it's not getting oxygen. Okay, when it's ischemic. That's what I'm talking about here. Okay, well, I've just discovered a nice little laser pointer here, so I hope this records well. So a PVC is premature ventricular contraction. And let's look at this EKG tracing here. Let's look at these waves. We have here, this first one, upward, is a P wave. Okay, you could put a little P above it. We call this the P wave, and it represents the atria of the heart are contracting. Then the very first downward deflection is the Q wave. So you can put a Q there. This is a normal Q wave. It's tiny. It's not pathologic. It's not pronounced or significant. It's just the first downward deflection. We call that a Q wave. This point up here is R. So we have Q, R, S. Put an S down here. From here to here, this little segment is the ST segment. And then we have the T wave. Okay, you can put a T over that. So we can put a P, R, and T. And that's just a single heartbeat, PQRST, PQRST. Now, instead of waiting for the next P wave to come, which is what's supposed to arrive at this time, the ventricles decide to contract. Whoa, 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 slow down your horses. You weren't supposed to contract yet. You're not supposed to contract until after the atria contract. So this came early. Now look how I'm circling this. This whole bizarre, wide complex is referred to as a PVC. This whole thing, don't try to make any sense of it, okay? At this point, just this is wide and bizarre. That's how they describe it. And then there's a little bit of an extra pause in here because we're waiting for things to come back to normal. And indeed, we get the P wave. QRST. Oh no, here we go again. Instead of getting a P wave, I find another wide, bizarre complex, which is a premature ventricular beat. And again, a little bit of compensatory pause, trying to get us back on track again. P, Q, R, S, T. P, Q, R, S, T. No, where's my P wave? It's not there because the ventricle contracted first. So here we have another PVC. So in this strip, we have 1, 2, 3 PVCs. So this is showing me that likely I have a very irritable heart. And these typically will precede ventricular fibrillation. Okay, so why don't we treat this now before it develops into a life-threatening dysrhythmia like VFib? Okay, and that's exactly what we would do. The medication we would give, we wouldn't wait. Okay, some students don't really understand that, but we're not going to wait until they develop VFib to give the lidocaine. We see an irritable heart with all these frequent PVCs. We want to start the lidocaine now. Okay, we want to soothe the irritable heart, and lidocaine is an excellent drug choice to get rid of that PVCs, those PVCs. Another thing we can note in this EKG tracing is that all of these PVCs look identical. Okay, they all look the same. They have the same form. Okay, same form. And what that means, and we can call them uniform, but what it means is that the cell, the myocardial cell that decided to initiate an impulse to cause a contraction originated in the ventricles. Okay, well, let's put it this way. It initiated somewhere other than the pacemaker. Remember when we talked about the pacemaker has the very same properties as every other cell in the heart. So any cell can initiate an impulse, but in a normal healthy heart, the pacemaker plays that role. Here we see that in an irritable heart, a different location, a different area of ectopy has initiated this premature contraction. Here again, we see the presence of premature ventricular contractions, and they're pretty easy to spot. Okay, we can easily see that this is wide and bizarre. This is not normal. This either. In fact, this one looks like this one, but this one doesn't look like either of them. So in this case, the PVCs have different forms, and it's referred to as multiform. Okay, so we'll just go through this real quickly. P being the atria contraction. First downward deflection is QRS, and the QRS complex, I didn't mention yet, is a normal ventricular contraction. Okay, this is a narrow complex. It's a normal ventricular contraction. And then it's followed by the T wave. And that's simply the ventricles relaxing. So we have P, QRS, T. Something wide and bizarre, a PVC. P, QRS, T. P, QRS, T. Uh-oh, I don't get a P. My next thing is a PVC. This is wide and bizarre. P, QRS, T. Another PVC. Okay, so again, this is demonstrating that in a short period of time, I've had 3 PVCs and I have an irritable heart. Lidocaine would be the drug of choice to soothe an irritable heart so that it does not advance and progress into a lethal arrhythmia such as ventricular fibrillation. Now here's another one that is easy to recognize. This is a life-threatening arrhythmia called ventricular tachycardia, or VTAC, as some people will call it, abbreviated as VT here. And don't try to identify PQRST of a heartbeat. Okay, you're not going to find it. Instead, we just look at the strip, and what we see are these, I hear 2 different things. You can call them large mountains, or you could call them tombstones. I personally like tombstones better because that reminds you that this is a lethal arrhythmia. Okay, you can certainly die. So what is happening here is that the ventricles, always go back to it being the workhorse of the heart, is now beating really fast. Okay, by fast, I'm talking up to 250 beats per minute. So what's the problem with that? We talked about it before. The problem with that is that there's no time for filling to occur. So what's going to happen to your cardiac output? Oh, a drastic reduction. In fact, you're not going to sustain life because you're not putting out enough. Your cardiac output is so decreased. Okay. Again, they're described as wide and bizarre in appearance. And there's nothing to identify. You just look up there and you recognize this tracing as being tombstones or life-threatening arrhythmia, VTAC. Now, going back to VFib, we said when we have an irritable heart and the PVCs can lead into a VFib situation. We said that the ventricles, the workhorse of the heart, is simply quivering or fibrillating. And when that happens, we get this chaotic electrical activity. Again, there's nothing to identify in terms of waves, like we don't say PQRST. You just look up here and you'll know, instead of seeing big mountains or tombstones, we see molehills. Okay, molehills, little tiny mounds that you might see in your yard if you had a mole digging holes in your yard. Okay, so we have this chaotic electrical activity, the small hills or molehills, indicating that the ventricles are simply quivering. Again, we have to realize this is life-threatening, and the reason it's life-threatening is because you're severely decreased cardiac output. Okay? The ventricles are not contracting, they're not moving the blood forward, they're just simply quivering. Okay? Now, we can save these people. This is great. So hopefully it doesn't get to this point. Hopefully we are going to see frequent PVCs, especially if they're in the hospital connected to telemetry, and then we can treat them with lidocaine and it never gets to this stage. However, if you see this on the monitor, then we have to treat it, and the way to treat VFib is to defib. That means defibrillation. That means we have to shock this person, okay? And so we will shock and hopefully get them out of this lethal arrhythmia. Before we shock, this is a reminder that we always do the verbal and visual check, because there will be a team of people in there. Make sure that nobody is touching the bed rail. Everybody is clear, standing away from before you deliver the shock. Okay, so we always do all clear, and then they shock. Okay, we don't want any bystander or any staff to get shocked. Okay, so that was our little introduction to lethal arrhythmias that can occur as the most common complication following an MI. But there are other complications as well. So the next big one that we want to address is the development of heart failure. You will learn about heart failure in tomorrow's lecture, and it has to do with usually a chronic condition, okay? But there is also heart failure which is acute, meaning it comes on suddenly. So this heart failure that I'm talking about as a complication of an MI is an acute heart failure, okay? So it's not the chronic heart failure, it's acute. And this can occur within like 24 hours after having an MI. But the nurse needs to be skilled and able to assess the patient for subtle changes in their condition. Okay, so these things, there's nobody going to be jumping up and down saying, oh my God, the patient's going into heart failure. No, you pretty much have to be like a detective. Some of these changes are going to be very subtle. Okay, things like this. Just a very slight dyspnea, like a little short of breath, especially with, any type of exertion. Restlessness. Look, that's your first change in level of consciousness. Okay, is the appearance of restlessness or agitation. You have to be really good with your assessments to pick up on these subtle changes. Okay, then there's also going to be an increase in heart rate, possibly JVD, and then you better be listening to those lungs, the bases of those lungs, for any crackles. Crackles are going to be your big indicator there that the heart is failing. It's not able to move the blood forward, up and out of the left ventricle. Instead, it's backing up and increasing pressures in the lungs, forcing fluid into the lung tissues. Okay, and we cannot breathe through liquid, so we don't want that to happen. We need to improve the functioning of the heart. This is a cardiac problem. It's not a respiratory problem, even though the symptoms present as respiratory with the shortness of breath and the crackles. But we have to fix the heart. We need it to function more efficiently, to move the blood forward so that we don't have those respiratory symptoms. Okay, so when we talk about heart failure after a heart attack, let's go through this one more time. An MI is an occlusion of a coronary artery. When there is significant damage to a large area of the heart, we can also have a complication of heart failure occur. The heart failure is a structural issue with the myocardium. Okay, and typically it's an overstretched and scarring of the left ventricle. It's not functioning well. There's left ventricular dysfunction, not able to contract with any strength to move the blood forward. Okay, so a complication of an acute MI could be an acute heart failure. There are other complications as well, but truthfully, I'd be happy if you can just get those last two. if you can remember that the number one complication is a lethal dysrhythmia, and a secondary complication, another one could be heart failure, an acute heart failure. There are others, but they're less common. And cardiogenic shock, which is heart pump failure. There's also, as was shown in this picture, a ventricular aneurysm, which is a blood clot in the left ventricle. Because this left ventricle is so weak and it's not contracting well, blood begins to stagnate and a clot forms. Okay. Also, you can have a complication of pericarditis, which is inflammation of the pericardial sac that surrounds the heart. And finally, you could even have a pulmonary embolism, which would be when some of the clot, perhaps the whole thing, becomes dislodged and travels then. It could travel from the right side as well. We could have clots form over here because you see, when the heart is not contracting efficiently and blood is not moving forward, it's only supposed to move forward. It's not supposed to hang out and stagnate, because then clots are going to form. And if clots form, especially over here in the right ventricle, remember this deoxygenated blood from the body, from the right side, is sent to the lungs. Okay, both sides. And if a clot forms because it's not moving well, clots could go into the lungs and result in a pulmonary embolism. So let's talk a little bit about this. Is another revascularization technique. This is open heart surgery called the CABG. Stands for coronary artery bypass graft. And this is the best option when there is multiple vessel disease. Okay? We've made it pretty simple as we discussed revascularization with the placement of a stent. Sometimes there's more than one coronary artery that's occluded. What if you have occlusions of 5 vessels or in 5 locations within the coronary arteries? Then we can't simply do a cardiac cath procedure, a PCI or a PTCA, in order to treat this patient. Okay, so in this case, multiple vessel disease, we would want to do an open heart surgery, and this would require a bypass graft. Okay, so if there is an occlusion, we need to get the blood, freshly oxygenated blood, using a graft to bypass the occlusion so that we can perfuse the area distal to the occlusion. Okay, the bypass graft comes from another vessel within that patient's body. Generally, it is the saphenous vein in the leg, but there are other places as well, including the left internal mammary artery is also used at times. The thing is, remember, these patients don't just have vessel disease in their coronary arteries. Typically, they are what I refer to as vascular disasters. So if we're going about looking for a graft, the chances of getting some good grafting material from a person who is a vascular disaster is not always easy. You want to select the best pieces or segments of the vasculature that are going to perfuse the myocardium. So sometimes that is a challenge in and of itself. So generally it's taken from the saphenous vein in the leg, but it can also be taken from the left internal mammary artery. Oh, one thing that we can say about this is that when you have open heart surgery, this patient is placed on a cardiopulmonary heart-lung machine. Okay, so because we have to stop the heart when we're operating on the heart, Okay, and we have to stop it so then the blood is not circulating or perfusing the rest of the body. So that's why we use that heart-lung machine to make sure that the body gets perfused during the surgery. Some nursing diagnoses for our patients who are coming back from open heart surgeries certainly include hypothermia. Okay, in the OR room, we are using room temperature fluids, and room temperature is much colder than body temperature. So they do come back very cold. We need to warm them back up. As well, they have acute pain. That's pretty obvious even by looking at this picture. And also, we're doing the surgery on the heart, and we hope that we have corrected the problem, and to make sure that they are having good cardiopulmonary functioning afterwards is going to be a big focus of your assessment on this patient. During the surgery, we have to make sure we have an airway, so they'll need to be intubated. And we have a perfusionist running the heart-lung machine to make sure that the gas exchange is occurring for these patients when they're under anesthesia. Afterwards, they have a large scar, usually down the entire length of their leg. And there is where there's a risk for infection with that. There's also a risk for infection with their mid-sternal scar as well. Disturbed thought processes, especially if they're not getting good perfusion to the brain, and certainly activity intolerance after a major surgery like that.